All right, let's get right into it. This is your Step 2 CK Final Sprint. No fluff, no warm-ups, just straight business. We're diving directly into a high-yield rheumatology, dermatology, immunology, and allergy management drill. We're doing rapid-fire, exam-facing cases focusing purely on those critical pivots that totally dictate your next best step. Let's get to work.
Section 1. We're looking at high-yield vasculitis recognition and critical emergency management.
Picture this. A 75-year-old presents with jaw claudication and sudden monocular blindness. What is the best next step? Pulse high-dose IV glucocorticoids like methylprednisolone. That Amaros' Fugax. It demands immediate escalation to save their vision. Don't fall for the trap of giving oral prednisone or, waiting around for a temporal artery biopsy first. Oral steroids would be the right move if this patient had purely localized polymyalgia rheumatica symptoms with absolutely no vision changes.
Okay, look at the aortic narrowing we're showing here. We've got a 25-year-old Asian female with upper extremity claudication and pulse deficits. What is her best primary medical treatment? Systemic glucocorticoids. Her demographics, combined with those pulse deficits, practically lock in Takayasu arteritis. A really common trap here is choosing IVIG and aspirin. But remember, that's the correct management for a 4-year-old presenting with Kawasaki disease, definitely not an adult with Takayasu.
Speaking of Kawasaki, a 4-year-old boy presents with a 6-day fever, non-exudative conjunctivitis, strawberry tongue, and a generalized rash. Which complication are we actively trying to prevent with treatment? Coronary artery aneurysms. That fever lasting over 5 days, plus the 4 mucocutaneous signs, confirms Kawasaki's disease. The trap answer they'll throw at you is preventing rheumatic heart disease. Rheumatic heart disease prevention is only correct for an isolated Group A strep pharyngitis.
Moving on to small vessel disease, a patient with hepatitis C presents with palpable purpura, weakness, neuropathy, and a positive rheumatoid factor. What's the expected complement finding? Low C4. Meltzer's triad, which is the purpura, weakness, and arthralgia, combined with Hep C points straight to mixed cryoglobulinemia, and that literally consumes complement. You might be tempted to guess normal complement, but you'd only see that in type 1 cryoglobulinemia, which is driven by a plasma cell dyscrasia like multiple myeloma, not Hep C.
Next up, a 45-year-old man presents with chronic sinusitis, a saddle nose deformity, cavitating lung nodules, and rapidly progressive glomerulonephritis. What is the most likely positive antibody? PR3 ANCA. This is your classic triad of upper respiratory, lower respiratory, and renal involvement, which indicates granulomatosis with polyangiitis. The trap is MPOANCA. That would be correct for microscopic polyangiitis, or EGPA, but those conditions actually lack these specific granulomas.
Section 2. Autoimmune and rheum cases. We're shifting rapidly into connective tissue disease here, really emphasizing severe multi-organ complications and strict diagnostic thresholds.
Let's test your logic. A 24-week pregnant woman with known SLE develops new edema, a malar rash, and her urinalysis shows RBC casts. What is the best diagnostic step to assess her renal severity? A renal biopsy. You absolutely must investigate lupus nephropathy severity physically with a biopsy to guide aggressive treatments, like cyclophosphamide. Don't just check dsDNA or complement levels. Checking complement is only the right move when you're simply trying to distinguish a general lupus flare, where complement drops, from an active infection, where it would actually rise.
Let's see how this builds into pregnancy complications. A 30-year-old pregnant woman has a history of 3 consecutive unexplained fetal losses before 10 weeks and tests positive for a lupus anticoagulant. What is the recommended treatment? Aspirin and heparin. Hitting the pregnancy morbidity criteria plus those positive antibodies completely confirms antiphospholipid syndrome. Avoid warfarin. It's contraindicated during pregnancy. It would be correct for long-term DVT therapy in a non-pregnant patient, though.
Okay, a patient with limited systemic sclerosis develops sudden-onset hypertension, papilledema, and microangiopathic hemolytic anemia. What is the best emergency medication? ACE inhibitors. This sudden severe hypertension in scleroderma defines a scleroderma renal crisis, which is directly driven by intense RAS activity. The trap here is reaching for calcium channel blockers. CCBs are correct only for treating persistent Raynaud phenomenon or digital ulcers, not a full-blown renal crisis.
A 55-year-old woman presents with severe dry mouth, multiple dental caries, and an abnormal rose-bengal corneal stain. What is the most accurate diagnostic test? A lip or parotid biopsy.
Looking directly for that lymphocytic infiltration confirms Sjogren's syndrome definitively. An ANA screening test is a trap. Sure, it's correct for an initial nonspecific SLE or general autoimmune screening, but it's absolutely not the most accurate confirmatory test.
Section 3. Allergy and Anaphylaxis Management. We're moving straight into critical airway and allergy rules. Zero filler, let's go.
10 minutes after eating a peanut, a child develops flushing, wheezing, and urticaria, but has a completely normal blood pressure. What is the best initial therapy? Intramuscular epinephrine. We have two organ systems involved here, skin and respiratory, and that equals anaphylaxis. Hypotension is not required to pull the trigger. Antihistamines are a trap. They are correct only for isolated mild cutaneous hives without any respiratory compromise whatsoever.
Let's push that exact scenario a bit further. A patient receives IM epinephrine for severe anaphylactic shock, but 10 minutes later, their symptoms are totally unresponsive and their blood pressure drops even further. What is the best next step? Intravenous epinephrine. A complete lack of response to the initial IM epinephrine mandates an IV escalation. Don't jump to intravenous glucocorticoids just yet. Those are correct only as an adjunctive therapy after the patient's shock is fully stabilized.
A completely asymptomatic, well patient has a routine checkup showing an isolated borderline to mild neutropenia. What is the best early default step? Calculate the absolute neutrophil count and repeat the CBC. The patient is totally well and the cytopenia is completely isolated. Jumping to a bone marrow biopsy or immediate escalation is a massive trap. Escalation or biopsy is only correct if there was a severe ANC drop, clear symptoms, other cytopenias, or splenomegaly.
Section 4. Dermatology and Skin Emergencies. We're shifting gears to high-yield rash pattern recognition and potentially fatal skin emergencies. Take a look at the skin findings we're showing. This patient presents with diffusely rough, dry, scaly skin on the extensor extremities that distinctly spares the intertriginous areas and gets worse in the winter. What's the underlying pathophysiology? A loss of function in the filaggrin gene. Chronic dermal scaling that actively spares the skin folds is classic for ichthyosis vulgaris. The trap here is autoimmune melanocyte destruction, which would actually be correct for the sharply demarcated patches of complete depigmentation we see in vitiligo.
A 3-year-old child presents with fever, irritability, generalized erythema, and epidermal shedding with a positive Nikolsky sign. What is the best treatment? Anti-staphylococcal antibiotics like nafcillin or vancomycin. Fever and epidermal shedding in a young child points directly to staphylococcal scalded skin syndrome, which is caused by an exfoliative toxin. Stopping a culprit drug like sulfasalazine is a trap in this specific case, but that would definitely be the immediate correct step for an adult presenting with Stevens-Johnson syndrome or TEN.
Okay, look at this ulcer. We have a rapidly expanding lower extremity ulcer with an irregular violaceous border and a purulent base in a patient with inflammatory bowel disease. What intervention must be explicitly avoided? Surgical debridement. The diagnosis is pyoderma gangrenosum, which is severely worsened by trauma due to pathergy. Immediate surgical debridement is a dangerous trap here, even though it would be the life-saving correct step for an infected abscess or true necrotizing fasciitis.
A patient presents with extremely pruritic erythematous papules localized specifically in the interdigital web spaces and flexor wrists. What's the best treatment? Topical 5% permethrin or oral ivermectin. Intense itching isolated specifically to the web spaces and flexures defines scabies. The trap is offering reassurance and long baths to remove scales. Long baths and moisturization are actually correct for managing the genetic scaling seen in ichthyosis vulgaris.
Final drill before the checklist. A patient presents with sharply demarcated small patches of completely depigmented skin on the face and hands. What is the best diagnostic confirmation? A. A Woods lamp showing absolutely no pigment. Or B. A biopsy showing absent melanocytes. Complete depigmentation that is sharply demarcated is classic vitiligo. Diagnosing tinea versicolor clinically is a trap here. Tinea versicolor would only be correct if the patient presented with partial depigmentation located primarily on the chest.
Section 5. Final exam day checklist. We are dropping right into it. No slowing down.
Here is your 60-second rapid-fire pivot sheet. Airway always first. Give IM epinephrine immediately for anaphylaxis. Remember, hypotension is not required if 2 organ systems are involved. Escalate to IV epinephrine if they are unresponsive. Always get a renal biopsy to dictate severity and SLE nephritis. Hit a scleroderma renal crisis with ACE inhibitors, absolutely not CCBs. If you see vision loss and giant cell arteritis, bypass the biopsy and push pulse IV steroids immediately. And absolutely avoid surgical debridement if you see a violaceous border in pyoderma gangrenosum. That's the drill.